Mike, at at Hopkins, you're at one of the premier institutions that have looked at this, with especially looking at androgen receptor variants, CTCs, those types of things. For our audience, can you give a little commentary about where we're moving in terms of trying to figure out, this type of testing?
Yeah, I think as Neil said, we have this paradigm that we treat things in sequence. We decide something is no longer benefiting the patient, then we move on. And yet, when you look at where you squeeze in Sipuleucel T, put it in early, but then if you go to your AR targeted agents, abiraterone or enzalutamide, you have no data to pick one or the other. Some data that's going to come out about potentially combining it. There's a negative study yesterday, from the British Columbia group that said that if you layer Abi and Enza together after progressing, it doesn't add any. It only adds toxicity, no benefit. So this whole idea of layering, still has sort of refinements, but I think is an important finding. But what we've done at Hopkins and other groups is trying to figure out, can we figure out who's going to respond to the AR-targeted drugs? And Jun Liu in 2009, showed one of the early AR variants. That is, that there is these splice variants that are basically constitutively keep the androgen receptor on. Other groups have shown similar variants, but the main one coming out is the AR-V7, and just early data suggested that if you had one or the other drug and you became AR-V7 positive, so it comes in either three flavors, that you don't have any circulating tumor cells, you have circulating tumor cells but they don't make AR-V7, those are negative, and then those that have circulating tumor cells and are AR-V7 producing, they're positive. That's the worst prognosis group. They do poorly, and yet we also showed that you are less likely to benefit from the prior hormonal therapy or using AR-targeted drugs in general. When you take that out to the real world in practice, we are finding that folks with AR-V7 positive can respond. It's low, 15, 20% max. So does that change your therapy? In our practice, we check, because if someone's progressing rapidly and I want to use a drug that's going to give them benefit, it tells me that I might want to switch to something like chemotherapy or radium. Whereas if they're negative, I might try the other AR-targeted agent from a side effect portfolio. So we're still trying to figure out that aspect. Assays across the country vary. Again, some centers can't find it, others can. So it still has a lot of work in terms of just becoming a standardized test.
Evan? So, so the traditional, this splice variant is a CTC. I mean, we're using CTCs. Again, I think Mike brings up a great point about reproducibility. What's been your experience on the West Coast?
Well, we're using both the EPIC assays and the QIAGEN assay. One's protein-based, one's PCR-based, similar to what you guys do in Hopkins. And, we haven't published all our data yet. We haven't found it to be as commonly available. That being said and done, there's just recent data presented yesterday for a trial where patients were being selected for having an AR splice variant and then going on to galeterone, and they found that only 8% of patients. Now again, these patients hadn't been treated with prior abiraterone and enzalutamide, so the rates were on the lower side to being able to find it. I think another question is it really a driver? Do we know, I mean, the biology is certainly interesting and nice that it can heterodimerize and homodimerize with other splice variants or with full-length androgen receptor and be constitutively active. But at present time, it seems like the full-length AR is still much more present than AR-V7. And my understanding is that if you have AR-V7, you usually have a lot of full-length AR and likely AR amplification. And could AR amplification be really the driver and this be a potential, dare I say, epiphenomenon? So again, I think the story is real. I think the biology is real. I just don't know how common it really is. And I don't know whether it's really the driver. Some could argue maybe it doesn't matter if it's driver, if it truly pans out as a predictive biomarker, that's fine. But the reason it matters is just that there are companies designing drugs that are specifically targeting splice variants, or and so will those pan out?
But when you talk about prediction, it can predict two things, whether you're likely to respond to another AR-targeted agent, that sort of continues to be sort of evaluated, and does it predict for a much shorter prognosis? So, you know, when you're looking at trials, how do you handle them, or if they're going to progress too fast? Can immunotherapy studies keep up with it? You know, what is it really telling you about that patient population other than, again, you need to be on alert. These are folks that are going to do poorly.
I don't disagree with you, but it's just nomenclature, you know. One's prediction, the other one's prognosis.
Right.
Nomenclature.